Hello, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thank you for joining us. I'm Alan Card, your host for today's session. As a bit of an introduction, I'm a research associate with the Center for Health Design. I've been working with the center on several projects, including the development of the CHD Online Safety Risk Assessment. I hold a PhD from the University of Cambridge and an MPH from the University of Florida, as well as professional certifications in public health and healthcare quality and healthcare risk management. My interests include intervention design and evaluation, especially as applied to safety, quality, and risk in healthcare and public health. I also serve as the editor of the Journal of Healthcare Risk Management. The purpose of the Evidence-Based Design Journal Club is to engage the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes and apply it in the real world. Continuing education units are available for this webinar through the AIA and from EDAC. To receive credit for your participation, you can download the forms at any time by clicking on the Show My Media Library icon, which is located in the top toolbar where the red arrow is pointing. You'll have access to the AIA quiz, the EDAC form, and today's presentation slides. To download a file, click on the green arrow next to the file. When you're finished, click the double right arrow in the top left corner of the media library. The library will close and the slides will refill the empty space. For EDAC credit, complete verification form and retain it for your records. You will need to submit the form to Castle Worldwide at the time of your renewal. For AIA credit, complete the verification quiz, purchase a CEU management fee for $10 from the CHD store, and submit the verification form to Catherine Anchetta. She'll upload the credits to your AIA account. You'll find Catherine's email address included on the form. I'd like to take a moment to review how to use the chat features so you can ask questions or submit comments on what you hear today. As shown on this slide, just type into the chat box where the red arrow is pointing. Please be sure to chat your questions to all so that the attendees on today's call are able to see your message. If you're having any technical difficulties, please type your issues to moderator in a private conversation, and we'll see how we can help. I would now like to introduce you to the three authors of the article we're discussing today, Debajyoti Pati, Tom Harvey, and Sipra Pati. Dr. Debajyoti Pati is currently serving as Professor and Rockwell Endowment Chair at the Department of Design at Texas Tech University. He has researched, published, and presented internationally on the intersections and interactions among physical design, people, and processes in healthcare settings. He was twice voted among the 25 most influential people in healthcare design and has received more than 10 national and international awards for research excellence. He currently serves as the Director, USA Chapter of the International Academy for Design and Health, on the Board of Directors of the AIA NIBS BRIC program, and on the editorial board of HERD. He is a fellow of the Indian Institute of Architects. Tom Harvey is a senior vice president at HKS. He has invested his career of 35 plus years as an architect, operations consultant, educator, and researcher in design for healthcare facilities. He is a fellow of the American Institute of Architecture, a fellow of the American College of Healthcare Architects, and is EDAC certified. His leadership and ideas have influenced an extensive array of environments for healthcare-related missions, with settings ranging from rural to urban academic teaching enterprises. He holds the distinct honor among these accomplishments of leading the naval design team designed for our nation's two hospital ships, the USS Mercy and Comfort. His passion focuses on optimal performance of the building that emerges from his practice. He organized and is a member of the HKS's Knox Advisors, Business Consulting, and is the president and managing principal of HKS's Center for Advanced Design, Research and Evaluation, CADRE, a nonprofit organization dedicated to rigorously distilling and disseminating quality research evidence relevant to the improvement of design. This focus has led to an innovative design approach intent upon informing design by operational discoveries and evidence from rigorous research in practice. Sipra Pati is a human geographer who has been conducting research in healthcare design for the past 6 years. She has worked with HKS Architects, CADRE, and the Center for Health Design. She has several publications in peer-reviewed and other journals and has been part of research projects that have been awarded by IDRA Core and IIDA. Her past research interests examine the spatial attributes of inhabited spaces, the conceptualization of spaces as a physical entity on domestic violence, and inhabitants' perceptions of space and employee behavior in industrial workplaces. Her work in the context of healthcare design draws on her understanding of these critical relationships. Thank you all for joining us today. As I mentioned, we are hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured article, Security Implications of Physical Design Attributes in the Emergency Department, from the Health Environments Research and Design Journal. On today's call, we will have an active discussion about key factors in your study. Thanks very much again for joining us to share your work. I was wondering if you could start off by giving us a little background on the study and the questions you were trying to answer.
So to start with, I'll give you a brief introduction and the background leading to the research, and we'll spend some time on the methodology and keep the bulk of the time to the findings and the implications. I know for sure we have a few people from outside of the United States in the audience, so I'll explain a few things that people outside of U.S. may not know. The emergency department in the U.S. is an important part of the hospital, and there is sufficient literature talking about it. It's one of the faces of the hospital. And depending on where the hospital is located, you could get as much as 30 to 40% of your admission into the hospital through the ED. So it is an important area in the hospital. At the same time, if you look at literature, it clearly talks about how dangerous it is. And in fact, the ED is one of the most dangerous workplaces in the United States. Both you can see the American College of Emergency Physicians and the Emergency Nurse Association have talked about it in recent past. Now, what has been known and the interventions that we have done in the ED context are mostly on the operational side. So we know, for example, long waiting and delays in care delivery has led to unsafe conditions or inefficient conditions that manifest in such things as impaired job performance, loss of staff time, and so on, staff morale. Now, the ED being a very important part in the hospital, and perhaps one of the most stressed out part of the hospital, because people who go in, by definition, are highly stressed, are in a condition that affects your psychology and stress level. And hence, when we look at the ED in terms of safety, security, and efficiency, we wanted to look at it from an architectural perspective, from a design perspective, and found that very little was available for our understanding. I was, at the time of this study, part of HKS Architects. I was in the role of a designer or a design firm, and we are trying to understand, or rather the question from HKS was, what can we do as designers to contribute to solution or solve the problem? And that was the unknown factor. If you look back at literature, very few studies were done in a systematic manner, in a scholarly manner, looking at the physical design of EDs and coming to some understanding as to what the sources could be and what kind of solutions there might be. Now, we will talk about some micro-physical design attributes that have been addressed in the past, but we'll come to that now on a slide that talks about the definition. So our question, hence, was from a physical design perspective that an architect or interior designer might ask as they are designing a hospital. And the first was, in what way does the ED physical design facilitate or impede the processes? And what are the domains of physical design decisions that potentially influence efficiency and safety of ED operations? I would like the audience to note that we are using safety and security together, but they are not the same concept. And I will talk about the difference between those two constructs in the next slide, or one of the next slides. Now, this presentation today is focused purely on security. And when we started the study, we looked at both safety and efficiency and trying to understand how the design, how things we manipulate affect those two domains. And as we started analyzing the data coming out of the study sites, we came to the realization that security and safety, although they are related concepts, the security itself can stand on its own as a separate paper for scholarly journal, as well as a separate presentation. So here is the two critical definition. I think all of us need to be on the same page so that as we talk about the design and implications, we will understand what those are. So security for this presentation and for the paper on which this presentation is based is a subset of safety. And when we talk about security, it is about protection of person and property from events unrelated to clinical procedures. That is the key word. So when we define security in this presentation, we are talking about all the things that are happening in the ED that is affecting person and property, but not related to the key clinical procedures and operations, whereas safety is the superset that includes things like medical errors and patient falls, and also all the security issues like ED violence. The other thing we need to understand as a group here is the difference between micro solutions and macro solutions. Now, these are terminology that we have used in the paper, and I think we need to define it. So in terms of micro solutions, these are things that can be addressed in retrofitting projects. So you really don't need to make big changes in the ED for these kind of solutions, like adding a card access lock or adding a CCTV camera. Whereas macro solutions are things that needs to be handled at the early design phase, because once built, they are very difficult to change, pretty much almost impossible, or it may cost a lot. So those are things like configurational concepts and functional zoning. And our interest in this study was not in the micro solutions, where if you go back to literature and do a literature search, you'll find that there are some literature on those areas. Our focus was on macro solutions, the things that you as I said, decide at a very advanced stage or at an early stage, and that cannot be changed subsequently. And there was very few literature on that, rather few literature, none. So with that, let me hand over the microphone to Sipra, who will walk us through the methodology.
Thank you, Alan. Before I get into the methods, actually, let me talk about my study size or our study size. This was a qualitative study, and it was exploratory in nature, and it was necessary to have the study size, the sample size limited. Before we went into deciding who would participate in the research, we had a list of criteria that would make the EDs eligible for the study. Some of the main criteria happened to be that they would be part of the EDs would be part of a larger hospital, and that they would be involved in a project that had a scope to expand, renovate, or replace the existing ED. The other criteria that we looked at, and which was not common to these EDs, was that they had a different patient volume, different numbers of exam rooms. They were differently located. We had 2 hospitals who were located in urban areas, and then there was one in a suburban area, and then one was in a rural area. So these are some of the criteria that we took into account, and we had 2 hospitals from South Carolina, one from Texas, and one from Utah participating in this research. Like I said, this was a qualitative research, and this involved multiple methods to collect data. One of the key methods of collecting data was gaming, and the other was semi-structured interviews of the ED management. We also collected data from the frontline staff in terms of touring interviews, where we walked with them and talked with them as they went through their work around the ED. And the main purpose of this was to gain an understanding of the ED process and its working. Gaming is a very interesting means to collect data, especially in an ED layout. And what we did was, and we needed a varied participant base. So we had people representing departments like respiratory therapy, nursing, imaging, pharmacy, security, administration, and even the management to participate in this research. The participants in the research in each ED were given two gaming boards, two sets of gaming pieces, and each of the participant team was asked to design an ideal ED process on one board and an ideal ED layout on another board. But before they started to do this, they were given certain information that pertained to patient volume, a number of exam rooms, and this information remains standard and unanimous across all participating EDs. The other instruction given to the participants was that as they placed these gaming pieces on the board, they were asked to speak aloud the reason behind why they placed a particular piece at a particular point. So, for instance, if a participant was placing a piece labeled waiting room next to a piece labeled triage, they needed to give the reasoning behind it. They needed to speak aloud their thoughts to the participants. They wanted to let them know why they were placing it, where they were placing it. At the end of each process, we gave each of the participants, a blue dot and a red dot. And the purpose was for the red dot was for them to identify a single point in the ED closed gaming board, and on the ED layout gaming board, they were asked to identify one pertinent point in the ED which was critical to either safety or to efficiency. The red dots represented safety and the blue dots represented efficiency. And this process, the process of placing the gaming pieces on the board and the speaking aloud of the thoughts, of the reasoning behind this, was captured to both video and audio means. The semi-structured interviews, they were also audio recorded. And then after these were, both of these sets of data were actually professionally transcribed, and we began the analysis by reading these transcripts. And when we started to read these transcripts, we documented the physical attributes mentioned each time by the participants as they're being relevant to safety or efficiency, as they're being, were they helpful, were they detrimental, or did they just stay neutral in the process flow of the ED or in the working of an ED. And what we also documented during this time was the context within which it was mentioned, who mentioned it. And we made little notes on the side of as we collated all this together, we kind of put notes on the side about the context and the person who was speaking about them. At the final process of the analysis, we collated all the information under separate thematic categories, as can be seen in the picture next to on the slide. And so each thematic category referred to a physical aspect within the ED. And that is where we concluded our analysis and went on to talk about the findings.
One thing I thought was interesting was a multidisciplinary gaming method used to help participants think through the design of an ideal emergency department. I wonder if you could talk a little bit about how you approached that and share any lessons learned that might help our listeners if they'd like to try using this technique.
Sure. Let me respond to that. So I have done a number of projects that involve interviews, observations, and each one of those methods have their own sort of shortcomings. But let's go specifically to the interviews. one of these struggle when you as a researcher is conducting an interview is trying to in our kind of research, we are trying to understand what role the physical environment has and how it affects people and operations and processes. Very few people in my experience actually think in terms of the physical environment. I mean, they may think in terms of the micro environmental solutions, like we mentioned, in terms of CCTV and car access locks. But very few people that I have met actually think in terms of the bigger sort of issues related to physical design. So it becomes a struggle or a challenge to conduct an interview and read between the lines and try to extract information relevant to architecture and interior design. So one of the things that we thought about was the reason we thought of the gaming is gaming as a tool. I haven't read a lot of research work where they use gaming, but I knew that in some of the programming, in many of the projects, people use gaming for a slightly different reason. So they bring people around the community around, let them play games so that the design solution that comes up not only represents the need or the hopes or aspirations of the community, but also they have develop some kind of an ownership for the solution. But the key thing happening over there is as people from 7 different departments in this specific case, who may or may not first of all think in terms of physical design at the macro level, and or they may not have even appreciated the interactions or the conflicts that occurs between departments, and which may affect the processes and which is also impacted by the physical environment. So when you put all of those people together and ask them to not redesign their ED, but design the ideal emergency department, they again, they are forcing themselves to think in terms of how do I design the process first, step one, and then how do I design the physical environment in their own way. And that is where they identify the conflicting areas. They begin to realize how the physical design is affecting them. So we got much richer data from the videotapes and the audio tapes of the gaming as opposed to any interview, because it was such a collaborative process and they were identifying the areas that impacted safety and efficiency. So I hope that answers your question, Alan.
Yes, thank you very much. And now for the good part, where we get to hear what you learned from all of this. It seems like you uncovered several important macro-level design attributes that contribute to security in the emergency department.
We did. But before we hit on those areas, let's go through a little bit higher level sort of discussion here in terms of what we found. So one, we have already sort of mentioned that the security and safety were related concepts, and anytime you have a security problem, it affects not only safety but also efficiency. So you could think of it as a storm coming into your community, and as the storm hits, it has ripple effect across the community, both in terms of safety of all the other processes, but also efficiencies across the operations. The key challenge here is if you could, nobody can predict this storm completely, but if you can predict it in advance, that may help you to take some precautionary measures. So that's where the security challenges come in. Now, so far as the bigger study was concerned that included safety and efficiency, the two big domains, it was published separately. And if any of the audience wants to get a copy of that, we will provide that information separately. But it had 16 different areas of physical design identified as affecting security and efficiency. Of those 16 areas that we as architects and interior designers handle, 5 related to security concerns. So let's talk about that. One was the entry zone. Then we have problems with the way traffic is managed from the door to discharge or door to disposition. Then you have patient room clustering issues, centralization versus decentralization issues, and the issues dealing with special population. And when we say special population, it's the behavioral health population that we are talking about. So let's go through each one of those in terms of what the key issues or key players were, and then we will look at the implications of those issues on design. Now, this is just a reminder of what Sipra mentioned when we were talking about the methodology. So just to remind you, each participant at all the hospitals had one red dot and one blue dot to place at the end of each session. So the gaming had two sessions, and on the left you will see the process flow that they designed for the ideal ED, and on the right is the actual physical design. And they were asked to put a red dot at one area they thought was really important to the security of the ED. And this is the same sort of similar image you'll see in all the gaming boards, that most of the people, participants, put their red dots around the entrance area. It doesn't mean that there were no security or safety concerns in the rest of the ED. They thought that was the critical area that needs to be handled first, and the rest of it would be fine. So that from that perspective, the entry zone assumes a very significant and important role. And when we say entry zone, we're talking about the walk-in entry, the ambulance entry, and the waiting area, vis-a-vis the way they are not only related to one another in terms of spaces, but also the way they're related to the registration and triage. Now, in terms of walk-in entry, the key issues were, or the key players were gang violence. That was one unpredictable thing that people were worried about and affect, again, safety and efficiency. You had behavioral health patients that was problematic around the walk-in entry, and even just accompanying family members of regular patients. Now, each one of these could spark a security system, situation. Ambulance entry, when it is not along with the walk-in entry, could have anxious, or even otherwise. You have anxious family members who specifically, when it is late night and they're arriving, could be a source of security concern. And in the waiting area itself, it is as the discomfort or pain level of the patients go up, that slowly becomes more challenging from a security perspective. So that sort of is an indication that you may end up with a security challenge. So here we are talking about understanding or having a bigger idea as to what's going on, who is coming in and who is going out, and really predicting a potential security challenge that may affect both the efficiency and safety of the entire operations in the ED. And when we talk about traffic management as an issue, it is about the flow of the traffic from the door to the registration triage and all the way to disposition and either into the hospital, or you are left home, or you go home. So that traffic itself becomes problematic when either you have crowding on the way, or if you are sending people back to a previous location. And time and again, pretty much in all the EDs, and many ED physicians and nurses I have talked with personally outside of these study sites agree that anytime there is a perception of negligence, which occurs anytime you send a person back to a previous location, whether it is the waiting outside in the entrance area or not, anytime they're reversing their way, that becomes a problem. So crowding and perception of neglect can trigger security issues, not only in the entrance zone, but any time all the way through the traffic from door to discharge. So that's one set of issues. The other set of issues really comes beyond the triage area, the main sort of ED space where you are delivering care. And there are two big issues over here. One really deals with are all the clinicians visible to one another? Now that has efficiency implications, which we are not talking about today. It does have security implications. And are all the patients visible from every work area for the doctors and the nurses? So both of these are sort of affected by the way we configure the entire ED. How many walls are there? How many doors are there? Are the visibility affected in, or are there clear line of sights or not? And all of these issues, as we will talk about in the implications section, are directly affected by the way we design the ED flow or ED walls. And these are bigger configurational issues. So the room clustering is the way we cluster the room vis-a-vis each team inside the ED or the ED as a whole. And then when we go to the care process, this is about how do we locate the support spaces, the medication, the supplies, the documentation areas, equipment. Where are these located? And again, it all goes back to one definition or one critical issue, that is, are people really visible to one another from the staff perspective, and are all the patients visible from for each staff? Because some of the challenges here are, including patients getting violent and challenging the nurses or the physicians, but also gang members walking in. And there are other issues that get directly affected, especially if you have sort of corners and corridors and walls that affect or restrict the line of sight. And then the final area that we deal with as designers is the rooms for special population. There are two big issues here. The population here is such a challenge, unlike other people, that they can harm themselves, and that is what we don't want to happen, and they may also harm the staff. So this is a big conflicting issue where you don't want them to see a lot of things that might aggravate them, that may stimulate them too much for them to react, but at the same time you would like to have them within your line of sight so that you can catch a situation or reduce a situation before it erupts further. So with that, so these are the 5 major areas affecting security. With that, let me hand over the microphone to Tom Harvey, who will talk about the implications.
Actually, before we move on from this section, one of our listeners had an interesting question. They're asking if you could clarify what you mean by efficiency. Does that just mean waiting time, or is it similar to effectiveness?
No. To me, efficiency and effectiveness are two different issues. Waiting time is one of the indicators of efficiency. Efficiency is basically, if you look at it from a 50,000 feet perspective and try to define it, it is how much resource you are using versus what kind of efficiency are you getting in terms of outcome. So a good example would be how quickly are you processing the patients through the ED. That would be an efficiency issue. How many rooms are you able to use, or how quickly can you turn over the rooms? And all of those are efficiency issues, which is different from effectiveness, because you may have a very efficient flow, doesn't mean that you are doing an effective job as a physician or as a nurse. I mean, the delivery of care may not be effective, but could still be efficient. And both of those are of interest to us. We would like it to be very efficient, but at the same, very effective at the same time. I hope that clarifies the distinction between efficiency and effectiveness.
Yes, it does. Thank you very much. So now you've managed to pull together a number of really useful findings here. How do you think we should go about applying them to the design of emergency departments in the real world?
Thanks, Alan. I've worked with these two scholars for many years, and I really enjoy trying to interpret what the findings are from their work into architecture. And the one thing that I always say about research is it's not a silver bullet. It doesn't specify specifically what you should do in design, but it more importantly just raises the key questions that you need to think about as you're preparing your designs and evaluating alternatives. So I'm going to go back through the 5 points that DJ outlined and just talk about these, the practicalities perhaps of this. The issue of entry zones, as DJ noted, is sort of the top priority for the staff that work within the emergency department, and the ability to see unobstructedly through that area as people approach the building, as they enter the building, as they move through various steps that are a part of that particular hospital's practice of engaging a patient in the emergency department. The ability to maximize visual contact throughout those areas is what we were hearing to be the most important component. Coupled with that is the awareness of security, and we've all been through many debates with owners about how you handle this awareness, this presence, the actual visibility of security elements of the design. And so you have to deal with that with every potential hospital client as to how important that is to them. But I would say what we're learning from talking with those who work in emergency departments is the increased value of some sense of security in the emergency department, the awareness before you even come through the door that there's going to be surveillance that's taking place to keep an eye on what happens in that emergency department is most important. We've had many emergency departments where a security officer is not necessarily present right in that entrance, but more often than not, that seems to be a valuable contributor to at least the staff having a greater sense of security by knowing that people that have entered that department have seen that presence physically as a person or through cameras or whatever the more microcosm tools are to achieve that. As we create designs and we sort of fit things into spaces and it informs of the building that we'd like to see as the outcome, we really need to go back to walking through that space and visualizing what it looks like, what you're going to see along the way as you enter that emergency department. I think the traffic management implications are important as well. One of the things that we all know exists in an emergency department is a high level of anxiety for the people that have come through that door for whatever purpose. And one of the issues that DJ mentioned of workflow through that area, the fact that you may present in a certain order and check in and then go sit down, and then somewhere in the process another patient comes in and perhaps is directed to triage and then sent back out to sit down. And that triage impact on the natural order of arrival in that waiting area is very important. I think we're all aware of it, but we perhaps don't put enough weight to that point of people observing that others are going into the emergency department when they came in after them, and therefore they're waiting behind them. So how do you deal with that? One way perhaps is dealing with the waiting area in such a way that it's broken up and there are smaller clusters of areas to sit so that people aren't just focusing on who comes through the door and what the order of that process is. But at the same time we do that, we need to make sure that the staff within the department has good visibility of all those perhaps smaller broken down waiting zones to be aware of everything that's happening in that space, as well as having some awareness of what's happening, I will say, behind them, if you will, in the emergency department itself. It's important to have both of those connections in this area. The one-way traffic flow comment that came from some of our subjects that were working with us in this research, at a first level, one might think come in one way and then discharge out a different direction. And that certainly may be helpful to reduce the level of activity happening in and around the intake point of the emergency department. But this comment also relates to what DJ pointed out of Many hospitals today are looking at operational approaches in their emergency departments that would have immediately upon arrival a larger type of triage zone where physicians are seeing that patient upon arrival. It's not a triage nurse. And those physicians may very well diagnose and discharge that patient out rapidly without even moving them deeper into the emergency department itself. That is another way to sort of manage the traffic flow and move some arrivers to the emergency department out more quickly and perhaps separately from the incoming folks in the waiting area.
One of our listeners had another question about this traffic management issue. They're asking, should we be considering also how people arrive and disembark from their vehicles and where they park when thinking through these traffic management and entry zone considerations?
Well, I think it's important that we consider that without question. It's really once they've arrived inside the doors that was a bit more of the focus here, but certainly the arrival sequence from a vehicle, if it turns into something frustrating or difficult and draws attention or needs help in that respect to get that patient in, I would say yes, it's very important to be able to visualize both that walk-in entrance as well as the ambulance entrance in that respect. I think we have another question.
Essentially, what we're reporting here is the data that we collected on site. None of the data that we collected really showed or talked about, or there was nothing in the data that referred to the approach to the hospital and the parking and so on. They were really concerned with the entrance door and what's happening immediately outside that. And I'm not saying that the traffic management outside of the entrance is not important. I'm pretty sure it's very important from making the hospital more user-friendly, making it, in terms of universal access, easier access for the elderly and people with handicap, and so on. But and I'm pretty sure it affects, public perception of what the hospital is and some form of efficiency of operations outside of the ED door. In this specific study, that area aspect of the ED operations did not come up as a security concern. So just to clarify, what we are doing so far, up to the presentation that I made before Tom came in, everything that we said was what was dictated by the data. What Tom is talking now is our interpretation of that data. So I'm just looking at one of the other comments here in terms of talking about homeless population as threatening. That came out of the data. The data doesn't say that homeless people are threatening. It just says that the staff of the hospital would like to have a visual line of sight so that they see who are coming in, and they gave that as an example. It certainly is not our opinion, either Tom Zipper or myself and the other people on the team, that homeless people are threatening. So we are just reporting what we found in a very unbiased manner. This section that Tom is talking about now is our interpretation, and I just wanted to clarify that.
Thank you for that. We did get another question as well about traffic management, and asking if these departments use or consider using numerical ticketing systems where patients have a visual cue to keep track of their placement in the process. Now, I know you did kind of cover the complications with something like that, but just was there anything like that in the organizations that you worked with?
I don't recall any address of that, but one of the things that, and DJ, correct me if I'm wrong on that, but one of the things this is a good example of the kind of tool that we as educated architects, think about as possible solutions to a problem. In this particular area, the numerical ticketing system as an example of a solution really, in my view, would serve to exacerbate the situation I was just talking about. People sort of observe when they came in and who's in the room when they go to sit down. And then they tend to notice who comes through the door next and next and next. So there's this kind of a mental image probably of where I am in line in all those people in the waiting room, which would be reinforced by that numbering system. The real challenge is when, if not all the patients coming through the door, at least some might be introduced into triage for a closer evaluation. And as a result of that, their order in terms of attention moves up ahead of people that are in the waiting room. And that's a common and generally appropriate practice designed to give attention as rapidly as needed for those that have a more urgent need. But I think in this case, having a number and sort of watching, particularly if you had a number popping up on a screen to say next, would probably exacerbate that problem. Just my thoughts on that.
So let me make a quick comment. I know we have two other areas that Tom needs to address here in terms of the support spaces and the behavioral health. So that's one of the reasons Tom mentioned about hospitals where doctors are doing the triage. And I think one of the major consideration over there is to eliminate that psychological issue that occurs when people are waiting, whether they have a number in their hand or not. And the quicker you take the patient inside, the quicker a doctor sees the patient, the better the perception that they are being cared for. They lower the perception of negligence. And one of the examples, I know a number of hospitals are doing this, but I am conducting a research right now at University of Colorado School of Medicine, and this is part of the EMF grant. So Dr. Jennifer Weiler, who is a PI of the study, is in an ED, whereas the patient walks in, they actually immediately see a doctor first. So they have a big waiting room as a physical design. Probably it occurred because of the way we were designing emergency room in the past, but they have completely done away with the waiting before they see a doctor. And I'm assuming that more and more hospitals are getting in that direction. Of course, it's a big operational question that the hospital has to consider in terms of putting a nurse or a doctor for the triage. But there are successful experiments in this line where the bottom line is, can we eliminate the waiting altogether or bring it down to the minimum in terms of 1 minute, 2 minutes, 3 minutes, and then you are into the process. And I think once you get into the ED and you are started to be processed, the psychological issues go down because you are already in the system, and then the security challenge is not that high.
You want me to go ahead, Alan? There's some questions here popping up as well.
We better get back on track, although I'm having a lot of fun with this conversation.
All right, let me hit these slides, and then we'll come back to these good questions that are surfacing. So with respect to the room clustering, again, reemphasizing that we're looking at a macro scale here, not the micro scale. And from with respect to this particular topic, it has to do with what we as architects begin to recommend as to how to arrange the space. And our clients may have strong ideas about that. They usually do in emergency departments. But we also have a role in introducing to them what has been done in other places that maybe better address or potentially better address some of these issues in emergency departments, to share with them the ideas that may improve upon, in particular, openness in the emergency department. This is a department where you just don't want any activities occurring other than within the patient room itself. You don't want any activities occurring that there's not a great deal of awareness about throughout the department. And as a result, there are certain types of plans that seem to work better than others in that respect. There have been some questions about pods and clusters that have surfaced, which the plan on the lower right you can see multiple clusters there of rooms around, whereas the plan at the top is a fairly linear layout with a great deal of visibility both inside the work core. This happens to be an on-stage, off-stage arrangement, as well as outside where the patients are coming into that space. This is not to say one of those is better than another. That wasn't the intent of this research. That really relates to what barriers does one configuration create that are greater than another configuration to visibility as well as auditory access between areas of that emergency department. It's both patient to staff as well as staff to staff visibility. And that latter one, that's reinforced by research that we've done previously. DJ and I started with a lot of research on inpatient units, which have a large floor plate, a lot of private spaces for patients. And many of us as architects at times try to break up that footprint in such a way by introducing curves or offsets and things of that nature in the corridors so that it doesn't feel like such a long, large environment. And we've repeatedly gotten feedback from the staff about concerns over visibility. And in this case, it's not so much patient visibility as staff-to-staff visibility. And in the emergency department, that is both a part of safety and security. But from a security standpoint, they're knowing that security is within eyesight. They're knowing that resources such as their peer staff are immediately available, or how far away they are critically important to that feeling like a safe environment for the staff. So as we think about creative ways to organize space, this is a department where we have to be very careful about not doing something that creates barriers to visibility. And the next slide relates to that as well, in that it's the operations, there we go, the care process. Things that we need for support services, medications, laboratory supplies. You know, that which is not in the patient room and immediately accessible is out in that core in some way. If we place it in the center core, sometimes by design that's a full height partition or something that's not very permeable with respect to visibility. And so there are many design ideas that are looking at trying to provide those kind of support elements in that core, but at a lower level so that they do not obstruct view throughout that space. The converse of that is if you put medication rooms or supply rooms off to the side, if not distributed, those become part of that efficiency concern that DJ was explaining earlier, that you're walking away to that particular space for your support purposes and at possibly losing visibility or being in touch with what's happening in the overall space. So that's a key challenge as we try to open up the work environment within the emergency department of how do we handle the basic support elements that the staff needs in that space. And the last slide we have here goes back to those populations. This is a challenge, particularly for smaller emergency departments, because when you get to a large department that's got a sizable volume that may be a part of the behavioral health and violence element in the emergency department, that may be a point where it has some justification to have created a separate zone where those patients have a higher degree of surveillance and security for themselves and for the staff. But the bigger challenge is most of our emergency departments aren't of that scale, and they have to blend together and maximally utilize their exam and treatment room space for all of these types of patients. There's no solution here, simply an observation that the population that's coming through the doors in emergency departments is increasingly a security challenge of sorts, not the individual per se, but the incident or the circumstance that has brought them into that emergency department. And again, probably the best thing to do there is visibility, sort of seeing where the action might be occurring, so that there can be proper reaction to that in terms of protecting patients and staff that are already in the emergency department and protecting that patient as well. So those are the highlights on those 5 points. There's one final slide here that has to do with limitations of this particular research study. DJ, you want to comment on those?
Yeah, this is typical of any qualitative study, and the reason we adopted a qualitative study is because there was nothing in literature already published about this. So it's very typical for researchers to adopt a qualitative framework, because that gives you the tools to go very deep into certain issues and lay out the world first, the world of ED safety and efficiency from a physical design perspective. And that enables subsequent research in more quantitative mode. So as we are doing a qualitative studies are not particularly best suitable for a causal analysis. I know there are qualitative researchers who disagree with me, but it's my perspective that if you want to understand causation, a quantitative approach actually gives you more strength or a bigger tool set. But these are associations that are there that we found in the data. What we don't know is how much is each one of those physical design elements or attributes affecting safety. So we don't know the magnitude of impact, but the data clearly shows the relationships. The second is we don't have a representative sample. Again, if I'm doing a qualitative study of this nature, qualitative studies cannot handle big sample sizes because of the extent of data we collect or the volume of data we collect from each site or each person. It becomes impossible to go for large sample size. And that's why we intentionally go for a sort of purposive sample that is as varied from each other, specifically in this case, as possible. But the thing we could have improved on in this research is by involving visitors and actual patients. We have not done it. So the next study, if someone is going to pick this study up and do a next study, a future study on this issue, I would suggest that let's include patients and visitors into the data pool or the subject pool in addition to the staff and the administration.
Alan, there's 2 questions on the table here, but I know you probably need to wrap up. You want us to tackle those?
Sure. First, I'd like to inform our listeners that the presenters have agreed to stay a few minutes late to answer your questions. But absolutely, if you could go ahead and take on those questions that you see on the screen there, that would be great.
Briefly. Okay, so there we go. That's what I need. All right, let me see if I can scroll back up. There was a question about fast track and let's see where we go. And urgent care. How does that play into the research? You know, our interest was in the participants mapping out their process, their workflow, but it was focusing on the security and safety aspects of that. Those 2 ideas posed are operational ideas, and DJ kind of referred to one of those when we talked about doctors seeing the patients when they come in the triage area. It's not exactly the same as fast track, but a similar idea that yes, if you can peel off populations, if you will, that can get quick attention and get out of there sooner, those are the people that oftentimes, if they're sitting in the waiting room, are observing a lot of other people going by them and getting care, which raises agitation levels at the least. So, but those are operational aspects that we all have to work with. You have to understand how the client wants to operate, but we should ask ourselves the question: well, how is that going to affect my ability to design a more visible and safe environment? And I would quickly respond to the other question of definitely the open plan cores, which I believe was the question, contribute extensively to this ability to provide a secure environment.
So let me add to Tom's discussion here, Tom's point. So let's step back. So we could think of a ED where there is no triage, no filtering going on, and everyone is sort of treated as per their order in the way they entered. Now, that's not feasible. It never happens in any emergency department, and any ED physician would say that's a bad idea and we don't do it at all. So then the question is, what was going on? So people would walk in, and then the doctors would look at each patient and decide how serious they are. They would take some people immediately inside, and they would ask the rest to go and wait. And that is where we were talking about the problem that was emerging in the entry zone. So part of that solution is, yes, fast track is part of that solution, where a lot of hospitals, pretty much every hospital I have been to, they are using some kind of a fast track. May not be across all 5 ESI levels separately, but at least they're taking level 4 and 5 and sending them in a separate route, and keeping 1, 2, and 3 in a separate sort of routing. But the challenge was the moment you, even with those kind of separation, the moment you send people back to the waiting area, there is a problem. So that's why you saw in one of the slides, the participants were designing the waiting area into separate zones, saying that each one of the ESI level, let's put them in separate waiting spaces instead of just one space. But that would assume that you have the traditional triage occurring with a nurse. So some people, as we mentioned previously, in some hospitals, they're experimenting and going a step forward, and they're saying, let's put a doctor in the triage. Then we don't even need the waiting area. As people walk in, the doctor would make a decision. The doctors actually make a decision whether they're level 4 or 5 or 3 or 2 or 1. And they would send the 4 or 5 into a separate area in the ED as opposed to 1, 2, and 3. So there are solid design implications in terms of creating separate areas for treatment, in some hospitals, or separate maybe rooms for them, whatever the case may be. And the way you design the entry area, if you're going with the traditional triage process with a nurse, then thinking about the waiting area in terms of how do we separate people with different acuity level into different waiting areas and still have the visual sort of line of sight between your greeting station or registration station and the triage and the security and the entrance and so on. So that's a pretty big design challenge. And yes, all of these decisions, operational decisions, do have pretty challenging physical design questions for us as architects and interior designers. So the bottom line answer is yes, fast track is a good solution. People are going a step beyond and putting doctors instead of nurses. And yes, all of those decisions do have a physical design implication. Now, people are going even one step further. They're saying, let's put internal sub-waiting areas as people proceed through the triage, so that they, in case of any time we need more, we have more people than the number of rooms that we have, that at least we can use those internal sub-waitings. And that's one of the questions we are looking at with the study that I mentioned at University of Colorado School of Medicine. And we expect to, we hope to see some improvement in efficiency because of those internal sub-waitings. So just hang on for a few months and we'll publish those findings.
Fantastic. Thank you. We're past the top of the hour now, and we're just going to try to hold on for another 5 to 10 minutes to get through some more Q&A from our listeners. Is there, I believe you had one more slide that you wanted to present. Is that correct?
And DJ was getting into some of this, but we always end these research efforts with identifying some next questions, if you will. So here are 4 of those, and you all probably would add to this list. But this is kind of beginning to go toward the macro of understanding some of these specific, the micro, so that we can better understand some of these macro components. So a real focused study on the question of, do direct sight lines better and truly provide security or improve security in this space? What can we do to test that specifically? Another might be the separation of waiting areas, as DJ talked about, for different acuity levels. Does that somehow influence or reduce violence in the area? The one-way traffic flow, again, is what DJ just talked about, of understanding if some kind of subweighting in the space is beneficial to improving security. And then that question that someone has already raised earlier of, how do pods versus open linear configurations perform in terms of some kind of measurable security outcome? So with that, let's open it to some questions.
Yes, please feel free to type any questions you may have, as you have been doing, in the chat box in the lower left-hand corner. I can get us started with one, which is, I know the focus of the study was on macro solutions, those things that need to be baked into the design from the start. But a lot of emergency departments aren't really in a position to start again from scratch right now. Are there any implications from this work that could be applied to micro solutions, redesign and refurbishment of emergency departments?
Not from a micro solution. That was not an area we were focusing on, but people who are interested in learning about the micro solutions, as I mentioned in the beginning, there are some literature on those, specifically in terms of things like card access. It's mostly on the security side, locking doors, putting CCTVs, and putting bulletproof glass in front of the greeting station or registration station, adding a security desk. So small things that might immediately give you an improvement in the security situation. I doubt any of those actually help in the efficiency part, because we have had no chance of discussing efficiency here. We're just talking about security. And my guess would be, again, this is not what the data is saying, my guess would be the more layers of security you put in, the more you are affecting the efficiency of operation, although you are creating a safer area. And that's maybe one of the questions we need to address next time. But that's the challenge with existing EDs. If you are not starting from scratch and you have security challenges, you add security, layers of security to it, and suddenly you see that your process is becoming inefficient because you have added layers of doors or walls and so on.
Great, thank you. We have our first question here. Is any thoughts about access to the ED ambulance garage in rural areas? Obviously not quite within the scope of the actual data that you gathered, but perhaps based on your experience of this and other work, you may have some insight.
Alan, I wonder.
Well, go ahead, Tom. Sorry.
Well, I was just going to say, if the individual raising the question could provide us just a little more detail about what they mean with this question, it might be helpful. I'm not clear on the question.
Well, what the data told us in this study is essentially, the best form of maintaining security is to keep the walk-in entry and the ambulance entry together, because that means that they don't need a lot of security staff, or typically they have a very few security personnel in the hospital, and they can monitor both the walk-in and the ambulance entry from the same location. But at the same time, by putting those two entrances together, you probably helps you in creating better lines of sight between the triage and the entrance and the registration and so on. Now, rural hospitals are pretty small. I have done some studies in rural areas. I haven't really seen a hospital of that scale where you would immediately lose visibility unless you have the ambulance entry somewhere, in the back of the hospital. So again, I would agree with Tom that this is a separate context altogether, and maybe it's an important question we need to ask as to what happens in a small rural hospital where they may not even have the security person or may not have the money to hire a security personnel. How do we design it? But first of all, maybe another question is, how important is safety issue in rural area? That's a good question to ask.
One of our questioners mentioned that they understand that FGI doesn't allow the two to be together, so that they
cannot be one and the same. But what DJ is talking about is a physical proximity. We always like to try to have visual separation of the activities between those two areas to try to manage confusion for the walk-in patient. But once you're inside, the ability to see both of those areas as much as possible from one place has always been a good idea. But as the EDs get bigger, or the site geography, topography, and so forth, are maybe a challenge to pull them together in that fashion. But this kind of relates to the efficiency aspect of security, of not having extensive separation where you really have to have two sets of staff from a security standpoint to observe those.
Sure. And from that site geography perspective, another questioner asks, do you think interpod visibility would be a good solution for visibility improvement?
Well, I'll speak from experience on that. We've had several times when we tried to design that, the plan seemed to make sense when you're drawing it and working with the user groups, but when it's built, there's been a high degree of dissatisfaction with the fact, and this really has to do with the scale of the ED and so forth. I mean, the one I'm referring to was an ED that was just large enough to perhaps create two zones. That while they were in a straight line, they sort of created pods, but there were some vertical elements that surfaced in that center core that inhibited visibility, and it didn't look so on paper, but it definitely happened when it was actually built. So there's one encouragement for building mock-ups, thinking about that, doing sight line mapping from every possible direction. But I couldn't say no, it wouldn't be helpful to work on that visibility between pods. It's just a challenge sometimes to really pull it off.
Let me add a couple points here. One is of the 4 EDs that we went to in this study, I believe 3 of those EDs already have some kind of a pod, a combination of ballroom, arena, and pod in their EDs. So as remember, they were in the gaming system or in the gaming session, not specifically for security. They're looking at efficiency, safety, and security together, and all the 7 departments were trying to design the best ED they can. In those hospitals that had already pods in their EDs, they tended to start with podular configuration as they were going from their process design to the actual design of the ED. They fooled around with it for a lot of time before moving away from it. So all of them, when they were together, all the 7 departments, especially the doctors and the nurses, as they were designing their own hospital ED, realized at a certain point in the process that, no, this is not going to work for us because of all the challenges now we realize because we are designing it. So at least based on what I have seen they do, they have done in the gaming sessions, at all 4 hospitals, they have moved away from pod configurations because of many issues, including the direct visibility between personnel and visibility between the clinicians and patients. Now, having said that, there was another interesting thing. I think many of us understand it, many of us don't, but that came out of the observations of the gaming process, that we talk about pods as a physical sort of configuration. Clinicians also use the term pods, but from a care configuration. So even though you may have a linear arrangement in your ED, they still, in their mind, create pods out of those linear configurations because that's the way they work. So we have to be a little bit careful here that when we say pod, we have to sort of add that we are talking about the physical design of pods rather than the way the clinicians do their own sort of separation of pods for assigning their staff.
Now, those kinds of trade-offs you were talking about lead in really well to our next question. But first, I'd like to take a minute to say if you're interested in emergency department design, next week the Center for Health Design is hosting an emergency department design workshop in Chicago. And if you check the chat box, you can see the link for registration. You also see here on this slide that there's a 10% off the registration with that registration code. Moving on to the question, it was, how do you develop a hierarchy between desired support spaces near staff areas and actual efficiency based on workflow and security?
That's a big operational discussion with your with your client as to how they want to supply within the room. Can we think about supply backup, if you will, in a way that is not the traditional 4 walls to a room and carts inside it, but perhaps there are lower configurations that allow sight lines over it. And we've had many circumstances where even medication areas in the past were in low configurations without a wall behind them. But medications in particular and supplies in general, we know from life safety codes or other codes relative to medications that we many times have to have that in secure environments. So if you can work with your client to determine a new way of providing a secure kind of configuration for medication so that they're more at hand in that core and not placed off at the end or at a distance where somebody suffers with longer walking to that location. Those are the kinds of interesting challenges we have to try to open up, that core within the emergency department.
So let me just add a couple points here, and I have to leave. I have another meeting coming up. So from an efficiency perspective, based on what I have seen in multiple hospitals, including our own research, the clinicians, that is the nurses and the doctors, whether in the emergency department or elsewhere, for them the best case scenario is you have available everything at the bedside, right? Because why do you need to walk 300 feet if you can get it in 30 feet? The challenge is not with the doctors and the nurses. The challenge is the other departments who actually come in and stock those up. The efficiency of those departments, the materials management or the pharmacy, they get concerned about their efficiency, their own departmental efficiency. And one of the things that happened in this gaming system is that because all of those sort of conflicting departments, mainly in terms of they thinking about their own efficiency and working within their own silos, because they're working together, that's where they started looking at those challenges not only in terms of physical design but as an operational challenge, and in defining, coming up with a common definition as to what do we mean by efficiency of this ED. Is it efficiency of the nursing staff? Is it efficiency of the materials management? Is it the efficiency of the pharmacy? What is it? I need to leave. I have another meeting coming up. But thank you very much, Alan and Tom and Cipra.
Thank you, Dean.
Thank you. Bye-bye.
Thank you all very much, all our presenters and all of you for participating. I'd like to remind you to save the date for May 25th for the next installment of the EBD Journal Club, an assessment of levels of safety in psychiatric units. Kat, did you have more?
No, thank you all for sticking around.
Thank you so much.
Thank you for joining.
The website will be open so that you can download your CEUs for another 15 minutes. Thank you. Bye, everyone.